Good. Well, thank you very much for this opportunity to share some of our data and ideas with you. And I start with this slide to remind us that I trained actually as a lipidologist. And I remember the days when in the lipid clinic, we had to make people drink sand that we called Questran, and we beat them with sticks, trying to make them run around and follow specific diets. And it was really pretty hard. But then we worked out that we can treat lipids by using really sensible medications such as statins by targeting the HMG-CoA system, and suddenly we now see a dramatic reduction in mortality because we are so good by using medication. So thinking about medicalizing medicalizing diseases such as obesity, or even thinking about preventing diabetes with medications may be as simple as thinking about preventing cardiovascular disease by using medications such as ACE inhibitors or statins. These are my conflicts of interest, and we work with lots of different companies, pharma companies, for medication, surgery, but also diet companies, because we don't think that you only need one treatment. We think that we need all the treatments. And I think if we think about our lifestyle changes, which is shown so eloquently by the two previous speakers, or we think of medication, or we think about surgery, what you've already heard so clearly articulated with the Finnish diabetes prevention study, it is the patients that responded to the treatments. It's the patients that had more than 10% weight loss that had the most benefits. So we are thinking of these responders and non-responders. And when we look at all of the data from medication treatments, but also from lifestyle treatments, it is not the smart people that listen to us that have a better response. It is a biological treatment. So if you provide a biological treatment that makes people feel less hungry and more satisfied, for example, a lifestyle approach or a medication approach or a surgical approach, it is going to work. But if you give somebody a treatment that makes them lose weight, but at the same time, you make the symptoms of obesity worse, if you give them a treatment such as a lifestyle treatment that makes the patient more hungry or makes the patient less satisfied, patients will not adhere to the treatment, not because they're bad people, but because the treatment did not have the desired biological change. And just if we think about any of the treatments that we give, nothing that we do in medicine works if we make the symptoms of the disease worse. So I think therein lies the principles that we have to do when we are thinking about our treatments going forward. I'm showing you an old study here, the Xendos study done with Orlistat, published back in 2004. And just to remind you that the placebo arm lost approximately the same amount of weight than we saw in the Finnish diabetes prevention study. And we also, so then if we take from that point that they had a 58% reduction on developing type 2 diabetes, then it's quite remarkable that a small amount of additional weight loss, as provided by Orlistat in the yellow line, gave an additional 37% reduction in development of type 2 diabetes. So we can see that more is better. We need more weight loss to get more effect. But that's what we need to strive for. And I think what we're going to hear more and more is about this double-digit weight loss. And you already heard it from the Finnish diabetes prevention study. We need to aim for 10% weight loss to really start moving the needle in the majority of people. Now, we have other medications, for example, Mysimba or the Contrave is known in the US. They don't yet have prevention data published, but again, in abstract form. But nonetheless, we can see here when it comes to the double-digit weight loss that even in people with type 2 diabetes, we can get a quarter of patients to achieve 10% weight loss. Now, the SCALE program that used liraglutide was an elaborate program targeting lots of different patient populations, but specifically targeting those in the SCALE obesity and prediabetes study, to see if we can reduce the risk of people developing type 2 diabetes. And just to remind you, it was a 2-to-1 randomization, and the patients who had prediabetes were followed for 3 years. And what we will see in this 3-year extension study is that the patients came from a large number of countries, but just to focus, the UK contributed significantly to this study, and therefore many of the results are very applicable to what we see. And some of the panel members, I know Barbara and others, were also part of this study. Now, this is an important aspect that was already raised before, is how they diagnose prediabetes. So in this case, it could be patients could either have impaired fasting glycemia or impaired glucose tolerance or a raised hemoglobin. And of course, it will come as no surprise to you that the patients who benefited most were that small number that intersected, that had all of these three combined. So certainly there are differences when we look at that's very much similar to what was seen in the Finnish diabetes prevention study. But here's one of the take-home messages. If you take a medication that works through biology, on average, you lose substantially more weight. So again, this is 3-year data. And again, the weight loss in the placebo arm that already had, remember, it was placebo plus diet plus exercise. You can see that these patients lost, again, weight that very much similar to what we've just seen presented by Jonathan Velabji. So 2.5% weight loss. So this can be achieved with diet and exercise in many different settings. But now remember, these patients already had a benefit. This 2.7% weight loss already gives you a reduction in the risk of developing diabetes. So what happens if you now have a medication that gives you additional weight loss? Now, on average, 7%. Now, 7% weight loss is not impressive. Let's just be frank with that. Most patients are not going to inject themselves every day for the rest of their life for 7% weight loss. It does not move the needle. But when we look at the distribution of weight loss, what we can see is that in over a 3-year period, half of patients with the medication plus diet plus exercise lost 5% of their weight. The group that we are interested in, a quarter of patients were able to lose 10% of their weight. But really, we are focusing on this 15% weight loss that's achieved in 11%. Again, looking at the baseline demographics, look at all the psychological questionnaires, it was not the intelligent patients that listened or adhered that lost the 15%. It was the patients who had a biological response. So the important take-home message is if you want to prevent diabetes, don't wait for the so-called motivated patient to walk through your door, because that patient has the same chance of responding to this medication than a completely unmotivated patient that walks through your door. So we need to stop blaming patients and actually think about how we can change the biology of their diseases to benefit them most. So looking at the percentage weight loss, we're really looking at double-digit weight loss, 10% or 15% weight loss that you can see can be achieved with a diet and exercise program. But the numbers are maybe 3% with diet and exercise and placebo getting 15% weight loss versus 11% with the medication. Of course, medications come with side effects, and these drugs are well tolerated, but we need to understand how to reduce the side effects where we can. And of course, one of the most important things that you can do is to stop the drug if it's not working. So if you give somebody a treatment that's not having a biological effect, stop it and move on. And I think that's also a principle when it comes to lifestyle treatments. If we give a lifestyle treatment that's not working, stop it and do something else. Either try another lifestyle approach or try a medication, for example. Because what we can see, and I'll remind you, again, the gray bar, the placebo group, who are, and this is the rate of developing diabetes, this is the diet and exercise group. This is as good as we have seen in the Finnish diabetes prevention study, as we've seen with the NHS program. But look now what happens if you give a medication on top of that. So now we see almost an 80% reduction on top of what you already achieved with diet and exercise, which is really very, very impressive. But it's not only about preventing type 2 diabetes. Imagine if we can turn the clock back, if we can take somebody with prediabetes and we can turn them into somebody who's normoglycemic. And I want to focus you on this number because we're going to come back to that in a couple of minutes. So 70% of patients treated with diet and exercise and liraglutide were able to become normoglycemic. So you are able to make patients reduce their risk substantially, and that really drives motivation significantly. But remember this number because we're going to come back 70% with liraglutide. And that is the reason why NICE has approved liraglutide for the management of overweight and obesity, not because it makes people lose weight. It approved it because the health economic model was driven by the prevention of type 2 diabetes and the ability to turn people into normoglycemia. And of course, the target population at the moment is people with a BMI over 35, with prediabetes, with a high cardiovascular risk, who is currently in tier 3 programs. And this is important that we are able to show that this is successful within the system, because what we would like to do is expand not only the patient population, but also where the treatment can be provided. Because again, remember, when we brought statins out, it was a hospital-only drug. But today, statins that are saving lives are being provided by general practitioners and are being provided in a really good way. So what does the future hold? And of course, semaglutide 2.4 milligrams is not yet licensed in the US or in Europe at the moment, but we have the academic study. So we can only hope that in future, these medications will be licensed. And again, the UK played a really important role here. And, the co-authors are Representative John Wilding, Rachel Battram, and Barbara McGowan, that's also on the panel. And this is a game changer. This is really one of these foundation drugs that's going to change the way we view a disease of obesity. Because at the moment, many practitioners view obesity as a psychological disease, as a disease where we have to ask people to behave. We even use terms like behavior therapy, like there's something wrong with people, they are subnormal and we need to just tell them to be better citizens. But if we have a treatment that could change the biology of a disease that they have, that they don't have control over, if this is truly a hypothalamic disease, that you and I can't use our cortical areas of our brain to think ourselves less hungry or to think ourselves more satisfied. And this hypothalamic disease drives the complications of prediabetes and diabetes. Imagine if we have a medication such as semaglutide 2.4 milligrams, that all it does, it doesn't make people smarter, doesn't make them more compliant, doesn't make them more motivated. It only makes them less hungry and more satisfied. And therefore, we get on average 16% weight loss. But again, that's not the interesting bit. The interesting bit is when we look at the number of people who can achieve 20% weight loss. A third of patients achieve 20% weight loss. And even if we look at double-digit weight loss, 3/4 of patients were achieving double-digit weight loss, 10% weight loss. Now, I want to focus you on the comment that was in the paper that 84% of the patients in the semaglutide arm were able to return to normoglycemia. Now, remember, with liraglutide, it was 70%. And now when we get this additional weight loss, we actually see 84% of patients turning into normoglycemia. And again, that is, a step above preventing diabetes. It's actually turning the clock back. So medications are getting much better, and I'm very excited about what the future will hold. But we should not forget about what we can already achieve with bariatric surgery. This is work from the Swedish obese subject study with Lena Carlson and Lars Sjöström, of course, both physicians, not surgeons. They are both internal medicine doctors, embracing surgery as a treatment to prevent type 2 diabetes. And you can see with these curves that whether or not you use banding, vertical banded gastroplasties, or gastric bypass, the effect sizes are incredible. when it comes to reductions of patients developing type 2 diabetes. Now, again, we get substantially more weight loss, but we also have some weight loss independent effects of the surgical treatments. And when we look at what are the predictors, we can see that, of course, body mass index is not a predictor for who is going to benefit most. So it's not the patients with BMIs above 45 that have more benefit than the patients with BMIs of 34. So it helps us to, again, not to pigeonhole people and to say, you don't qualify for this treatment because you are not heavy enough. In fact, we need to look at the biology, that it's really the disease severity, be it either fasting glucose or baseline insulin, that are predictors of who benefits most. So a recent paper published by Sam Klein's group in the New England Journal, excellent paper, showed that if you take patients with recently diagnosed diabetes that are able to respond, and you give them a good diet approach and get 18% weight loss on the left-hand panel, then what you are able to do is you are able to turn them put them in remission, and of course you can see in the insulins, also recover on the left bottom hand side. But look at the patients who were relatively easy to control. They didn't have difficult to control type 2 diabetes, but if you give them a surgical treatment, they also can return to a baseline glucose that is in the remission range. So, if you work with people who are recently diagnosed, again, whether or not you use diet or surgery doesn't make a big difference. But you can see from the bottom right-hand panel that what surgery does is it enhances insulin secretion much more than we see after diet approaches. So therefore, it also helps us to understand that if you use treatments, for example, that has a weight loss independent effect, such as surgery, when it comes to insulin secretion, or a weight loss independent effect, for example, GLP-1 treatments that has an insulin secretory benefit, you're going to be able to be more successful. So let me summarize by saying our strategies to prevent diabetes needs to follow the same strategies that we use for all treatments with chronic diseases. We need to have the self-directed lifestyle changes, public health messages, the professionally directed lifestyle changes, as was shown with the Finnish diabetes prevention study and what the NHS is rolling out now. But if that does not work, don't trap people in that cycle and make them do it over and over again. Escalate your treatment and consider adding medication. Again, if that's not good enough, escalate to surgery, or even use a combination approach between surgery and medicines so that we can prevent the complications of obesity, such as diabetes and prediabetes. So let me conclude by saying any weight loss strategy that can be maintained is likely to prevent diabetes. We have responders and non-responders to all treatments. And if somebody responds to a lifestyle treatment, keep them on it and let them continue as long as they possibly can. But if they don't respond, move them on to another treatment, such as a medication or a surgical treatment. And especially those treatments that have weight loss independent effects can be helpful to prevent diabetes. Please allow me to thank the team at home that's doing all the hard work. And I'm very happy to take some questions. Thank you.